important to know about the nature of injury, the mode of injury, what was the object, whether it was a blunt object or whether it was a penetrating injury. It's very important to take the history properly. And then the medical history, you should ask for risk factors for HIV and hepatitis, the current tetanus prophylaxis, and recent food injection for anesthesia. The history taking should also involve the mode of injury, whether it's the type of object involved. And in the examination part, you should see whether it's a full thickness eye wall defect. If it is a full thickness eye wall defect, then it's called an open globe injury. And lamellar lacerations are classified in closed globe injuries. And you have to see whether it's a blunt object or a sharp object. If it's a blunt object, it's called a globe rupture, and the sharp object can cause a corneal laceration or a corneoscleral laceration. Okay, so you get a call from the ER, and then you have the postgraduate saying, I have a globe rupture here, ma'am, and then they say penetrating injury, perforating injury, etc., etc. So 3 terminologies for one case. So that's very important to know the terminologies correctly. So what is a globe rupture basically? See, you have a trauma with a blunt object. So what actually happens here is you have the deformation of the globe. So there is a lot of intraocular fluid here, right? Intraocular pressure increases. And there is no way that intraocular pressure can be transmitted elsewhere. And what happens is the pressure is transmitted to the eye wall, and the weakest part of the eye wall gives way. So that is called a globe rupture when you have an injury with a blunt object. So here in this case, the patient has had a graft. So the graft is the weakest part of the eye wall now. So the graft is given way, and what you can see is a graft dehiscence, and you have a dislocation of the lens. So this terminology is called the globe rupture. So always remember, globe rupture is with a blunt object. When you have a penetrating injury with a sharp object, it is called a laceration, a corneoscleral laceration. And then if it's an entry and exit wound, it's called a perforation. So that is what is given in the Birmingham eye trauma terminology system. When it comes to ocular trauma, there are 2 things that you should be very thorough with. One is the Birmingham eye trauma terminology system, or the BETS classification, and the other one is the ocular trauma score. So Birmingham eye trauma terminology system is again the same thing, the open globe injury and the closed globe injury. What you should remember is a partial thickness lamellar laceration is also classified in closed globe injuries. Welcome to director. In closed globe injuries, you have a laceration. Open globe injuries, you have a laceration and a rupture. Like I said, it can be a penetrating injury or a perforating injury. And you should also be thorough about the ocular trauma scoring system. Now, what is this trauma scoring system? We have a raw score based on the initial visual acuity. So no PL is 60 and PL or hand movements is 70. And based on that, based on the initial visual acuity, you have a raw scoring. And then a minus 23 is given for a globe rupture, a minus 17 is given for endophthalmitis. And other poor prognostic factors are if it's a perforating injury, if there is a retinal detachment, and if there is an RAP. So you have to say 70 minus 40, 23 plus 70. If the patient has a globe rupture as well as an endophthalmitis, it is 40. So 70 minus 40, then it comes to around 30. So it is between 0 to 44, which means it is a poor prognosis. So ocular trauma scoring is very, very important to give a prognosis to the patient. So you can give whether the patient has 0 to 44 is poor prognosis. So 95 to 100 is, 92 to 100 is very good prognosis. So you look at this case. Externally, you will think, okay, this guy has had a very poor, very bad ocular trauma and is going to have a poor ocular prognosis. But that might not be the case because it's more of an adnexal injury and a conjunctival tear, and not much of a loss of vision or a retinal detachment or endophthalmitis or an RAP. So when you look at the ocular trauma score for this case, it is pretty good and the patient has a good visual prognosis. So again, you just don't go by the external appearance. There are a lot of postgraduates here, so I want you to get the terminologies right, whether it's a globe rupture, whether it's a penetrating injury, perforating injury, a partial thickness, full thickness, ocular trauma scoring should be done properly, and the BETS classification should be done properly. So coming to non-perforating mechanical trauma, intraocular foreign body, corneal foreign body, and a corneal aberration, you cannot take it lightly. Mostly, these are dealt by the first years, but then you cannot take it lightly because we see a lot of infectious keratitis in cornea clinic, and all those patients have a trivial trauma wherein a corneal aberration is not treated properly. So nothing should be taken lightly. So when you have a corneal foreign body, please examine it under slit lamp. assess the depth of the penetration, and please do a removal under slit lamp. And if it's a deep foreign body, then you have to remove it in a sterile operation theater. It's usually associated with rustering, and when you have a rustering, you can have a smoldering inflammation on and off. And these patients have to be taken care because these patients can end up having a corneal facet, or they can end up having an infection. So it's very important to see that. If it's a glass foreign body, you can have multiple glass foreign bodies embedded in the cornea, and sometimes if it is deep, you have to take it in the theater. Now, this anterior segment OCT picture was given by Dr. Nikhil Gokhale. So you can see the posterior lamellar laceration, and then you can see the intraocular foreign body lodged there. So these foreign bodies have to be dealt with very carefully. You have to do a side port and do it carefully. Otherwise, what will happen is the foreign body can actually drop on the lens, and it can cause a lenticular opacity, or it can cause further damage. It can even penetrate the iris. So these kind of intraocular foreign bodies have to be dealt with very carefully, and you should also do a gonioscopic evaluation of the angle. So when you have a corneal aberration, see whether there is any associated inflammation. Otherwise, you can just put them on topical antibiotics and put a pad and bandage, or you can sometimes even give a bandage contact lens. So look at this case. I'm just presenting some case scenarios. So this was a 12th standard student who presented to us with a history of, he was riding the bike and something fell onto his eye. So he was, when you probe further, he says, I don't know, I'm not very sure whether it's an insect. So you look at this picture, you have a corneal edema, DM folds, and if you look very carefully, there's some stromal infiltration here, and there is a streak hypopyon here. So what actually happened is probably an insect injury. So in these cases, you always have to invert the lid and see whether there is an insect wing. Mostly the insect wing can be lodged onto the upper lid, back of the upper lid. So what actually happened with this case is, it was a stinger. I had a picture of the stinger, but it's not a very magnified view. The stinger has actually caused the local inflammation. It can release the toxins, and it has caused the corneal inflammation and edema. I took him to the theater, and then I removed the stinger from this portion, and then gave an intracameral wash, anterior chamber wash with intracameral antibiotics, and used air for tamponade. So most important point is you always have to invert the lid, ask about the history, see what is the inciting factor. Now this was a case which presented us to us during Diwali season, gives history of bursting crackers, and then there was no cracker injury directly, but there was an instant stick probably, and the patient had an incessant cry. And one take-home message that I would like to tell all the postgraduates is, if you have a child crying, do not try to examine with a torch. You're not going to get any information from that. Either you have to sedate the child and see it in the operating theater, or otherwise pacify the child and see examine properly. Again, examination of the lid is very important. You have to invert the lid. You can see an instant stick at the back of the lid that has caused this kind of a thermal injury to the cornea, as well as that's why the child was unable to open the lid. So this paper on impact on the pattern of ocular injuries and awareness following a ban on firecrackers, published in Indian Journal of Ophthalmology. But when I was before joining Ophthal, I think I used to burst boxes and boxes of crackers. But after joining Ophthal as a first year postgraduate, and after doing duty as an assistant, you get at least 70 to 80 cases of firecracker injuries during your duty. That's when I stopped bursting firecrackers, and I always tell it everywhere. It's very essential to bring about a ban on firecrackers. The amount of trauma and the devastating corneal injuries it causes, not only corneal injuries, even posterior segment complications, are very high with firecrackers. And Professor Natarajan sir is also on the course, and he has also been promoting. He's been highlighting this cause. The ocular signs of perforating trauma, if you have a trauma like this, it's very obvious, but sometimes, it might not be very obvious, and that's when you have to pick up an occult scleral tear. So what are the clues? You can have a 360-degree hemorrhagic hemolysis. If you have a 360-degree hemorrhagic hemolysis, sometimes it can be just SCH, but you have to see the tension digitally because it can be an occult scleral tear. And in those cases, the tension will be very low. Okay, and then you can have sometimes peaking of the pupil where you have focal iridocorneal adhesion, a shallow anterior chamber, hypotony. All of these are pointers to a ocular trauma, which can be very subtle and which can be missed. Okay. So what are the ancillary investigations which we do? You do a CT orbit and extra orbit in case of intraocular foreign bodies. We also do an ultrasonography for assessment of posterior segment after suturing the corneal laceration. And if it's a blunt injury, definitely you should do an ultrasonography. And if you think it's infected, then you should send a culture. Earlier intervention is always better. A stitch in time saves 9. Why? Because you can have collapse of intraocular contents, suprachoroidal hemorrhage, microbial contamination. Many times during the COVID period, we've had many referrals from other places where the corneal tear was not sutured and the patient proceeded to us after 2 or 3 days. And all these cases, ocular trauma, it has to be dealt as an emergency and it has to be done as soon as possible. That will give you very good results. So a delay in intervention, you anticipate a delay in intervention, then keep the patient on nil oral and start intravenous antibiotics and tetanus prophylaxis. GA is better for not only pediatric cases, even for very bad ocular trauma cases, because the peribulbar, the retrobulbar injection can increase the orbital pressure and it can cause extrusion of orbital contents. So if it's a very bad ocular trauma, it's always better to go for a GA. So this is the algorithm which we follow. And if you have an injury like this, where you have an adnexal injury as well as a corneoscleral tear, then it's better to do the corneoscleral repair first, and then you have to do the adnexal injury. Because if you're going to do the adnexal injury first, then what will happen is you will keep giving pressure on the globe, and that can actually give a collapse of intraocular contents. So corneoscleral lacerations first, and then adnexal injury next. If it's a partial thickness, like I told you, you can do a pressure patching, and you can also put the patient on a bandaged contact lens. Always remember, cycloplegics have to be given. Even if there's a small epithelial abrasion, give a cycloplegics, and then the bandaged contact lens should remain in place. We also use tissue adhesives like cyanoacrylate in case of small corneal perforations. If it's a very large perforation, any perforation less than 5 millimeter, now we started doing a and this was published in Tamil Nadu Journal. So this patient is again a case of firecracker injury, a male with a firecracker injury. He actually presented to us with a picture like this, where you can see corneal edema, and then very closely, if you see, you can see a small perforation here on slit lamp, and then the tension was very low digitally. The Siedel's test was positive. So when in doubt, always do the Siedel's test. Okay, so this case, we did put a pressure bandage, a bandage contact lens for 1 day, and 24 to 48 hours we observed him, but it didn't work out, and then we had to take him up inside the theater. So in the theater, we did a tuck and T-notch for him. The T-notch patch is taken to the supratemporal quadrant, and it is anchored with overlay sutures. One advantage is it's just done with overlay sutures, and we are not using any glue. So glue is costly, so we are not using it. And the patient also had a cataract, and the patient underwent a cataract surgery later. And this is a post-operative picture. You can see the anterior segment OCT where the T-notch tissue is nicely integrated in the wound. Okay, so surgical repair of simple corneal laceration is very, very important for all the postgraduates. So how to go about the suturing technique? The suturing, the 10-0 monofilament nylon, you should actually use it in 90 to 95% of depth through the stroma. It should be equal on either sides. What will happen if you put a shallow suture? Then you can have a posterior wound gaping. And if it is through and through, then you are actually introducing the microbes from outside into the anterior chamber. So your depth should be correct, your length should be correct, 90% depth is what is recommended, and the length also should be correct. And the suture knot should be buried. Please go and practice suturing knot burial in the wet lab. All the knots have to be buried. It has to be buried in the stroma, because if you're not going to bury, then obviously it is going to incite vascularization, and loose knots can attract epithelial debris and infection. So this kind of an overriding and overriding and other complications happen because of the unequal depth and length. So please, with practice, I think all of these techniques can be improved, and you can avoid a lot of astigmatism and corneal blindness as well. So when you have a limbus to limbus corneoscleral tear, probably you have to use long sutures peripherally, and then central cornea you have to use closely spaced shorter sutures, avoiding the visual axis. When you have a stellate corneal tear, you start from the periphery and then you keep coming to the center. Center, if there is a perforation, probably you have to use a tissue adhesive, or you have to use a patch graft. That's how a triangular flap closure is done. Many times when we suture, we notice that the lens is intumescent. So if you have a good data setup, then probably you can take the lens in the same sitting as well. If you have a proper foldable IOL and all that. The problem is you just have to go with the 21-day IOL. If you want to do a proper correction, then probably you can take it up in a later sitting with the proper calculation of intraocular lens power. Uveal tissue prolapse, whenever you're excising the uveal tissue, please do not pull the tissue or the vitreous. That can cause some traction, and later on you can have retinal complications. So you should not exert traction of the vitreous, and if it's a necrotic uveal tissue, if it's more than 24 hours, then you can abscise it. Corneal scleral wound suturing, again, like you have to start with the limbus and then proceed to the corneal side and then the scleral side. So this again is a case of a hemophilia who had a blood staining of the cornea due to trivial trauma. One important thing that we have to pay attention is the intraocular pressure. So these cases, intraocular pressure can be measured with an IK tonometer. If it is 35 millimeter mercury or it's above 50 millimeter mercury, then you have to do a paracentesis. Because blunt injuries, glaucomas can cause the blood staining of cornea. And here again, you can see the blood staining of cornea. This is one important question for the examiner as well. Differential diagnosis for blood staining of cornea is dislocated lens in anterior chamber. So the procedure that was done for this case was the triple procedure AB sir did this case. That is a penetrating keratoplasty with a cataract extraction and intraocular lens. This is a forceps injury. This is just a 2-day-old baby. Neonatal, very rare to get neonatal injuries. Mostly it's due to forceps. But if they had applied fortified antibiotics initially, we could have avoided this fulminant type of keratitis. This child had a pseudomonas keratitis and it went for a corneal melting and then done a therapeutic keratoplasty. It was not done with the ophthalmic microscope. It was just done with an ENT microscope in the pediatric hospital. So you can't expect much there because pediatric anesthesia is not available here. The secondary repair of intraocular trauma like vitrectomy and cryotherapy and all will be dealt by Natarajan sir. The post-operative management is just like any other cataract surgery, topical antibiotics and corticosteroids. You just have to put the patient on systemic antibiotics as well, and cycloplegics are a must. Follow-up is very, very important for ocular trauma because like I said, if the sutures become loose, then you have to remove it. And if the sutures are not removed, this is what will happen. A patient will have a vascularization. So advise a corneal SR after 3 months and then frequently monitor the retinal status and the intraocular pressure for these cases. Visual rehabilitation has to be done because most of the cases of corneal tears will have astigmatism. So if it's a pediatric case, then the patient will land up with amblyopia. So you definitely have to give them glasses. The take-home message is proper suturing techniques, proper history, and post-operative timely SR and visual rehabilitation is a must. Another cause of ocular trauma is chemical injury. So you can have acid injuries as well as alkali injuries. Just a couple of slides more. So you have to document the limbal ischemia, the stromal involvement, the corneal involvement, the clarity, and how many clock hours are involved and what is the inciting factor. So you have to do a copious wash, put the patient on topical steroids and antibiotics, and amniotic membrane transplantation according to the grade. So Duval's grading has to be done, and amniotic membrane transplantation has to be done. And Thenon's advancement is done in case of limbal ischemia. And the sequelae of chemical injuries can be very devastating. You can have loss of corneal clarity, and this is because of the limbal stem cell deficiency. Here you can see the loss of corneal clarity and vascularization, conjunctivalization cornea. The fibrovascular pan is covering the cornea. You can have partial LSCD or total LSCD with chemical injuries. Now this boy had a uniocular chemical injury. So you can see it's a grade 4 chemical injury. You can see the fibrovascular pannus and symblepharon. So you can see the almost near total LSCD. So what we did for this case is take the limbal stem cells from the other eye. The other eye was normal, and so we are able to take the limbal stem cells from the other eye. So this is a procedure called auto slet where you take the limbal stem cells from the other eye. So the fibrovascular pannus is cleared, and then the entire cornea is cleared. So the limbal stem cells are taken from the other eye. Okay, so the limbal stem cells are taken from the other eye, and then the limbal stem cell explants are placed onto the amniotic membrane. You place the amniotic membrane over there, and then so the amniotic membrane acts as a scaffold for the limbal stem cell explants. The limbal stem cell explants are kept in the not too much periphery, about 10 to 12 explants, and then fibrin glue is applied over it, and then we put a bandage contact lens over it. So that is a post-operative picture after 3 months or 4 months. So this child had an uncorrected visual acuity of 612 and a best corrected visual acuity of 6.9. So uniocular chemical injuries, at least there is a possibility of taking a limbal stem cell explant from the other eye. But when you have a bilateral chemical injury like this, where the other eye is gone for Keratitis, it's not possible to take the limbal stem cell explants from the other eye. And then we have to do a simple limbal explant stem cells. We have to take the stem cells from a cadaveric donor. And this procedure is called an alloslet. So simple limbal epithelial cells were taken from a cadaveric donor, and this patient had a visual acuity of 2 by Tsd, and after cataract surgery improved to 6 by Tsd. But then since we're taking the limbal stem cells from a cadaveric donor, we have to immunosuppress the patient for at least 2 months before we do the procedure. And after the limbal stem cell the alloslet also, we have to immunosuppress the patient for a very long time. That's the disadvantage with alloslet. Thank you for your patient attention.
Thank you, ma'am, for your exhaustive talk and excellent presentation. Sir, have you joined, sir?
Sorry, hello, Dr. Sharma. I have joined.
Yes.
Present, no? So I think I can in a few minutes and read. In the meantime, can you do a question answer?
Question answer, sir.
No.
Okay,
you can follow your talk. You can have whatever question answer. I'll come and join you.
Okay, sir.
Yeah.
Sure.
I'm online on the way, but I want to present it from the laptop.
Okay, sir. Sure, sir. Thank you. So if there are any questions, so suturing technique is very, very important, and I hope all the postgraduates go to the wet lab and practice suturing well and do all the corneal test suturings well. Do you have any questions on ocular trauma? We see a lot of infectious keratitis and ocular trauma causing corneal blindness, and that's why we have chosen this topic for this eye donation fortnight. We had different corneal topics, but then we wanted to have an ocular trauma session so that we can promote to a large extent how to prevent ocular trauma. Ma'am, you want to say?
We should talk about something else, how to feature the Natarajan or Rupture too. Because if it's third, it takes some more time to come into.
On the way.
Dr. Sharmila, am I audible? Hello?
Yes, ma'am. Thank you for joining, ma'am. Tell me, ma'am.
If you have stellate or irregular corneal tear, which you usually come across, is there any ideal procedure to be followed?
Yes, ma'am. I have seen the late corneal test. You have to start from the periphery and keep coming to the center. Mostly you'll be able to close it, and the center you can use purse-string sutures to close the center. And in case we're not able to do it, then probably you have to do a small patch graft for this place. Now we started doing a tuck and T-notch patch graft for corneal perforations. I think we had a mobile blast injury, and Dr. Perry Naik ma'am had actually used a small corneal tissue for doing the patch graft. It was more like that case. I think that case was all over the paper too. So that was punctured in the center, and she closed that central thing with a patch graft, corneal patch. So either we can do a target T-notch also, we can use a T-notch tissue to close the central perforation, or if it is not closed by persistent sutures, then we have to go for a patch. Would you like to add something on adnexal injuries now since you joined?
Sorry?
Would you like to add something on adnexal injuries? We get a lot of adnexal injuries with canalicular tear and all that, right? Would you like to add something on that?
Yes.
Is it better to do the canalicular repair then only, ma'am, or can we wait and take it for the secondary repair, ma'am?
We have to do a canalicular tear as a primary surgery.
Okay.
Okay, you're using the Monaco stent.
Yeah, you can use here we are using the RO stent. Sorry for I'm not advertising, but we are comfortable with that. It's cheaper and effective also. Most of our cases we are using RO stent. And as a primary procedure, whichever type the patient walks in, we are trying. Most of them are successful.
Okay, ma'am. Thank you.
Thank you. Dr. Sharmila.
Yes, ma'am. Tell me more. Yes, ma'am. Yes, ma'am. That's what I mean, we may not get a good refractive outcome because the intraocular lens power calculation and all might not be done at the time. But then sometimes, like if you do it under GA, then you can probably couple it. If it's an intumescent lens, and you think, you're not able to close the wound properly and it's basically continuously. Otherwise, it's better to do it as a secondary procedure because the intraocular lens power calculation and other things can be perfect and we can have a good refractive outcome. So mostly what we do here is do the corneal suturing and then do a clear corneal phaco aspiration, irrigation lens aspiration, and then do a foldable IOL.
Thank you.
Thank you, ma'am. So. Thanks to Mo for helping with all those technical things. Really pathetic at that. Okay, so this was something that I pressed in AOS, and so probably I'll just take you through this, some of the cases. So this again is an important cause of corneal blindness, infectious keratitis. So it's very, very essential to treat them properly. And this is one case that the postgraduate always gets. I think a lot of postgraduates have logged in, so probably I thought I'll just touch upon this as well. So it's very essential to differentiate between a bacterial keratitis and a fungal keratitis. So you look at this kind of picture. So you have a nice creamy suppurative lesion. So that is that goes in favor of a bacterial keratitis. Here you have a dry, dirty-looking ulcer, and here you have an elevated epithelial plaque. This elevated epithelial plaque is very, very characteristic of a fungal keratitis. Sometimes you can have a mixed infection where you have a bacterial keratitis as well as a fungal keratitis. So always do the examination in order. Like you have to start from the face, look for any lesions of herpes zoster, see for any mebomitis. The lid examination is very, very important for a case of keratitis. See for any trichasis, ectropion, entropion, lack of stillness. Unless you look for it, you cannot make it out. So it's very, very essential. And then the corneal epithelium is a major barrier for infections, and if there is something that compromises the corneal epithelium, like a pseudopegibullous keratopathy or a neurotrophic keratitis, then it can be a huge risk factor for keratitis. So the examination has to be very proper. So you have to cover from all this, from general examination, blisters, facial palsy, to the eyelids, lacrimal sac, conjunctiva, and the precorneal tearful. The conjunctiva, you should also look for vernal catarrh because the upper lid papillate can actually give rise to a shield ulcer. So this is how the grading of the ulcer is done: the size of the ulcer, the depth of the ulcer, the infiltrate and scleral involvement. And it's very important to know about these papers when it comes to microbial keratitis. You should know about MUT 1 and 2 trial and the TSD protocol. Can anyone here tell me what is TSD protocol? It's the topical, systemic, and targeted therapy. Like you start off with topical drugs, and then if it's a huge ulcer, then you go for systemic add-ons like oral fluconazole and oral ketoconazole or oral oriconazole. And targeted therapy is intrastomal oriconazole, or you can give an intracameral antibiotic combined with an intracameral antifungal like amphotericin B. And this mycotic ulcer treatment trial is a landmark trial which was conducted by the Arvind group. So it concluded that septate filamentous fungi is the most commonest cause of fungal keratitis in South India, and natamycin works well against septate filamentous fungi. So there's no point in adding, like cocktail of medications. Many times we see a prescription where you have atropine, fortified cefazole and ceftazidime, natamycin, oriconazole, and all such drugs. There's no point in adding so many medications like a cocktail. Too many cooks only spoil the soup. So you have to add specific targeted therapy. So if it is fungal, you add natamycin. Natamycin works well and it's more effective than oriconazole. So the classification of fungi, I think the rest of it you must be knowing. What is important is the uncertain classification of Pythium, Pythium insidiosum. So what are the features for Pythium insidiosum? You have this. It comes from the unidentified fungal isolate. It's an oomycete. It lacks ergosterol, and that's why the usual antifungals do not work against it. Diagnosis made when there is worsening with antifungal therapy. You think it's fungal keratitis, you keep on adding natamycin or oriconazole, and it doesn't respond, and that's when you suspect a Pythium. Very characteristic feature of Pythium is this ring infiltrate, and you have this tentacle predictions. You have this tentacle-like projections, and that is a very classic feature of Pythium keratitis. You can even have small pinpoint infiltrates surrounding the main lesion. Diagnosis with 10% KOH mount and calcoflow stain, and treatment is with linezolid and oral azithromycin. This case, I think it's very, very important again for postgraduates to diagnose this case. So what are the features here? You see a conjunctival lesion, ocular surface lesion, which is encroaching the cornea. You can see some feeder vessels here. You can see some gelatinous appearance here. So it's very characteristic of an ocular surface squamous neoplasia. There are different variants. You have this leukoplakic variant where you can see this white variant here, gelatinous, papilliform, and pigmented. Pigmented OSSN can actually be like demataceous fungi. So that can be a differential diagnosis for demataceous fungi. So the Sliclam examination, you have to see the feeder vessels. The ocular surface staining has to be done with rose Bengal. You have to do a gonioscopy to see for any anterior chamber angle invasion with by the tumor cells. The regional lymph node examination has to be done, and then impression cytology. If it's a very early OSSN, you can do an impression cytology. Otherwise, excision biopsy is the gold standard, and you have to stick to excision biopsy. So that's the anterior segment osity of an OSSN. You can see the hyperreflective epithelium here, and you can nowadays with an anterior segment osity, it is actually it's a paradigm shift in the management of OSSN. You can actually see the extent of involvement also, how much depth is involved. So grades of OSSN, many times, PDs get confused with this grades also. It's very, very important. Look at this picture, look at these pictures. So see, so it's very important to classify it as mild, moderate dysplasia and severe dysplasia. Carcinoma in situ. In carcinoma in situ, there is complete involvement of the epithelium, but there is no breach of the basement membrane. There's no breach at all, and that's very, very important. So after this, it is classified as benign, and we don't start any topical chemotherapy after excision biopsy. But after this, you call it as invasive squamous cell carcinoma, so it becomes malignant beyond this point. So there is a breach of basement membrane. You can see the cells invading. So this is invasive squamous cell carcinoma. Please don't be confused about this point. And this is when we start a post-operative topical chemotherapy. So what is this technique called? It's called the Shields no-touch technique. So there are 6 steps to it. One is you do the excision biopsy. So the corneal part you have to do with alcohol. You have to do the epitheliectomy. The conjunctiva part, no touch. No touch means you're not touching the tumor part. So you have to touch, you have to mark the margins 4 mm beyond the tumor, and then you have to excise from there. Conjunctiva tenonectomy, then you have a lamellar sclerectomy. So you can do an anterior segment OCT, see the depth. If it's too deep, you can probably do a lamellar sclerectomy for 0.2 millimeter depth. Okay, and to prevent recurrence, you have to do a double freeze thaw cryotherapy and amniotic membrane transplantation. And please send the excision biopsy. You can draw it like this and send it for histopathological examination. So the pathologist will give us a diagnosis like this, whether it's non-invasive or invasive, and whether there is a positive margin. If there is a positive margin, then you have to do an adjuvant chemotherapy. If it is a negative margin, then just follow up the patient. If there is a positive margin, invasive squamous carcinoma, then you have to do a re-excision. Positive base, you have to do a plaque brachytherapy. Nowadays, topical chemotherapy has actually changed the role we manage ocular surface squamous neoplasia. This is an old article by Santosh Manohar sir. Now we have switched on more over to topical chemotherapy, interferon alpha. Interferon alpha has actually changed the game a lot. So you can start off pre-op with, you don't have to do an excision biopsy at all. You can do a debulking with, chemo reduction with interferon alpha. So this one is a vernal keratoconjunctivitis with limbal stem cell deficiency. The other case I showed you limbal stem cell deficiency, right? So this, why limbal stem cell deficiency? Because there's loss of corneal clarity, there is conjunctivization of the cornea, and you can see the corner truntus dots around. Okay, so this is a case of vernal keratoconjunctivitis. So whenever you see a case of VKC, you should not, so this again is a major cause of corneal blindness. So what happens here is, VKC can cause a limbal stem cell deficiency and corneal blindness. So if you treat it early, if you treat it when it's mild, when it's in the papillary form, probably you can prevent this kind of blindness. That's very, very important. So shield ulcers, all of this can be prevented if you treat the patient properly. So you have to do the step-ladder approach with mast cell stabilizers, then steroids. And then, you can start intralesional steroid or systemic steroids. Systemic steroids are nowadays being used commonly if it is a very bad VKC. This I have already covered. Limbal dermoid, again, there's a lamellar patch graft being done for a limbal dermoid. This is Shakti's case report of ophthalmic image. It's golden hour syndrome with situs inversus. Peripheral ulcerative keratitis. So infectious keratitis in PUK, obviously, you have, if you manage it well, we can prevent corneal blindness to a large extent. These are things that we cannot modify, inherited corneal dystrophy. So the only thing that we can do is a lamellar keratoplasty or a penetrating keratoplasty. This is a corneal hydrox, and this is very interesting. So you have this kind of a picture with the corneal blindness. You do an anterior segmentosity, you can see the aqueous pockets in the stroma. So what we did for this case is did a paracentesis and iridectomy through that, and then pneumodesmatopexy, because you have the desmus rupture here, right? You have the desmus rupture. So you can do venting incisions and clear the aqueous pockets, and then you can also use air tamponade. You can use a air bubble to attach the desmetopexy. If the ideal one to be used is an SF6 or C3F8, but those agents can actually cause pupillary block glaucoma also. So air seems to be a very safe option. If you do a proper PI, then it will not be a pupillary block. So again, so again, we have to follow up this case with the keratoplasty, but then at least preliminarily we can manage the case. And if this scar, if the descemet's tear is not in the central visual axis, if it's in the mid-periphery periphery, then probably the visual axis will be clear and the patient can see to some extent. In this way, we can at least postpone the keratoplasty, and the patient will be symptomatically relieved also. Thank you. Thank you for your patient attention. You've been listening for a very long time.
Thank you, ma'am. Your expertise were like just like that, premier expertise, clearing many of our doubts. Sir, you're on the way, sir.
Hello. Yes.
Where are you, sir?
I'm just crossing. What is that? Near entering the commander in chief road on the market.
Okay, sir.
In 2 minutes, I'll be. Escape.
Afternoon, sir.
Good afternoon.
On behalf of IOUH,
Should we connect the? Do you want to connect the? Oh.
I kindly request Chief of Corneal Services, Professor Dr. Prahlad to give a momentum to Natarajan sir. Thank you, ma'am. Thank you, sir. All the way.
Automatic. Sir, I can share the screen. Thank you, Dr. Prakash and Dr. Sharmila and all the students and faculty here. I'm always feel nostalgic coming here. I keep repeating this. Prakash will get bored with me. Yeah. So can you see the screen? Yeah. So my talk is on ocular trauma and management of posterior segment complication. At this juncture, I want to congratulate Regional Institute of Ophthalmology, Dr. Prakash, and the entire team. I saw in the group that you have done the maximum number of trauma surgery during COVID. And I think at the same time, I think we should also, I represent Ocular Trauma Society of India, International Society of Ocular Trauma, and also President of Asia Pacific Ophthalmic Trauma Society. So with this, I think my only request is you should publish in IGO, Sharmila, your work. And also, congratulations for tackling the mucormycosis, which was, I think, you have done a great job, and I saw a lot of people congratulating. So I think the team, entire thing goes to the leader, Dr. Prakash. And I think it's important because everybody has a role, and I think GOH should have the role all the time. It should be the prime. I'm happy 2019, we celebrated 200 years of 200 glorious years of modern ophthalmology in India, and the whole world celebrated it. And we had a GOH big picture there in the indoor conference, and they did it on their own. I should thank them. They also made a museum, which is in Delhi, and now I am also part of the American Academy of Ophthalmology Museum. So, external trauma include, I heard corneal trauma in the neck, and also the main thing is even in an nopial eye, one should undergo a primary repair, even when the success rate is less than 1%. And with this, I actually had guts to operate in Kashmir, I should say, because I went alone. And the name of I keep telling this in the way, if you go through New York Times, a lot of things have been written about me. And I think the name of the hospital is Shri Maharaja Hari Singh Hospital, which is a Hindu name, because Hari Singh ruled Kashmir. And then the name of the surgeon is Natarajan, another Hindu name. Rest, everybody was Muslim. But I think when we taken a Hippocratic oath, no cross, creed, religion, no politics. So I went and served there. I went 5 months, every month, 4 days. So a lot of patients I operated with NOPL, and studies have done on NOPL eyes. It was only 20 years ago, Bob Morris reported on their attempts to reconstruct 11 eyes with severe ocular trauma that could not perceive light. And the author succeeded in restoring some function in 7 out of the 11 eyes. And the World Eye Injury Registry, which was again formed by Bob Morris and Ferenc Kuhn, who was the current president of ISOT, 28 of IAs of no PL was done, and 21 regained light perception. You may ask, what is the point in getting no PL to PL? But I think if you meet that person who had vision and then who have lost both eyes, and then no PL, and then you get some PL. I think for them it's a world of difference. And I have several patients like that. And then the other is ambulatory vision, who has got 20/200. That means he can go to the toilet, he can see his own plate and eat his food. And I think no joy of otherwise you have to feel and take it. So strategic thinking in ocular trauma is required, whether it's an anterior segment or a posterior segment. I always said that ocular trauma does not know the boundaries, whether it's an anterior segment or posterior segment. We have made it. And my friend, late Cesare Forlini, always used to say, you should do that means from cornea to optic nerve. And even though I manage, but I don't do everything except posterior segment. So for managing, you need strategic thinking, which is there in management, the individualized approach. Think again and again, what's the most suitable line of management for a given patient. So that's why I'm happy to say I've done the maximum number of posterior segment surgeries in repairing. And this must have its basis in the scientific literature and genuine personal experience. I fully agree with the reference that the surgeon must not act on a trial and error basis, but according to this plan. And this is also published in the journal. So choose wisely. Indication for a single thing, which are not going into the detail, or to perform a two-step approach. So this is like a organized vitreous hemorrhage with intraocular foreign body. This is all operated in Kashmir. And I told the patients that don't come here, I'll come there and do it free. I'm telling it free because neither the government of India nor government of Kashmir took care. And thanks to the Borderless World Foundation, which is an NGO based in Pune, asked for a surgeon to come. And I thought I was the most experienced surgeon in the world to go and operate. And this is a vitreous hemorrhage is being cut and being removed. And what you see yellowish white, the otherwise it's called the chicken fat. That means the patient has come a few days after the vitreous hemorrhage has happened. So one technique which I have made is I make sure that the pellet is within the vitreous hemorrhage. And when I identify that, I make an incision, which is superiorly between 11 o'clock and 1 o'clock. Both the conjunctiva and the subtenons have been opened up. And the idea is to make a wide incision without disturbing the 3-port, which is I use the 23 gauge sutureless surgery, and diathermize the sclera so that you don't have bleeding, and make a scleral incision and 3.5 millimeter. And that's why you have to do a good wound excision, a good base excision. And this is the extension I'm doing. Better to have and this is a 4-pronged forceps. Thanks to Manish Bapai, Mahesh Shanmugam, and myself, we have designed this, published in the Indian Journal of Ophthalmology. And we graft the pellet within the vitreous hemorrhage. The reason is, if the pellet if the vitreous hemorrhage is clear, the pellet will fall on the surface of the retina. And even though it's not having weight, but I think when you're trying to remove, you can have problems. So that's why I do this, so that this is the pellet, which is a 4x4, which is a polygonal shape. Then close the scleral wound, the congenital wound, airtight, watertight suturing, and then proceed with the 3-port pars plana vitrectomy base excision. And I'm using the retinal brush to clean the surface of the retina. And you see subretinal, preretinal, also suprachoroidal hemorrhage in the inferior side. And also you see the impact side. So you can see the subretinal hemorrhage. I'm not going to disturb that, but I actually do the barricade laser as though treating a coloboma choroid. That means that wherever the subretinal hemorrhage is there, I just do a laser. You can see the laser is around the entire subretinal hemorrhage, and in some places where the impact site was there, or where the through and through which has happened, we don't meddle that, but make sure the vitreous is not attached to it. That's the scaffold. And you can see the optic disc and macula, all right. These sort of patients can get 6.6, 6.9. If it is a phakic, we prefer to do a secondary IOL 2 months later using the part. Again, I leave it to the anterior segment surgeon to do the And then the majority of intraocular foreign body should be removed on an emergency basis because of the risk of endophthalmitis. I heard Dr. Sharmila talking about endophthalmitis. And if it is delayed, it becomes increasingly difficult to remove the foreign body because of fibrous membrane which will form over the foreign body, organized vitreous, and also retinal detachment with PVR. This is a video which I borrowed from Dr. Major General Parihar, polyocular trauma, sports injury. You can see dialysis and you can see total cataract. And if there's a cataract like this, I actually let the cataract surgeon do the phaco intraocular lens, and then I take over and then proceed. Here is also facing a glaucoma valve. And so the patient has traumatic dialysis, planning the surgery where, as I said, trauma does not read books. We write books on trauma. So since it's not my video, I mean it's self-explanatory. He's making a scleral fat, then also making a 3-port entry, and then doing a lensectomy. So he also does lensectomy, vitrectomy. And you can see lens matter has fallen down, retina is attached, the media is clear, optic disc is healthy. So with all this, I think the patient can get a good recovery. So any injury, according to me, should be prevented. So I'm actually recommending our Ocular Trauma Society of India to do advocacy. So I'm actually also planning a PIL against crackers. And some people said the people in surrogacy will lose job. No. And I think unfortunately already Chinese market is integrated. The people are buying Chinese products. And we should buy our own Indian product. And I'm from Tenkasi, which is near Sivagasi. We will always support Sivagasi. And I think child labor should be avoided. Cracker injuries. I think last year there was a fire in Sivagasi. So I think we have to find a way to do this all advocacy to prevent the injuries which can need not happen. Now here you see he is doing a repair for the dialysis and making sure making a cosmetic pupil as well as, because all this is required so that the patient does not have photophobia, and also the pupil is again formed, and he is now placing the glaucoma valve so that and again I think you all most of you probably are aware. So if it drains in increasingly, you can have hypertony. And we recently had a patient who had severe hypertony, produced choroidal detachment, and then had following the retinal detachment. And then I operated now. But I think the main thing is, and this is here, he's showing a open globe injury, and this is a sclerocorneal tear. So you have to identify, the idea problem is to identify the edges. So sclerocorneal junction is the best to start, and then go from periphery to the center so that corneal alignment is proper. But you can see this is done exactly in the optical axis. So this patient may need PK in the future, but I think the first surgery, the most important surgery. I'm glad when I went to Kashmir, I'm like, everybody was well trained. 25 faculty were there. 25 were done fellowships wherever they have done. They had cornea fellow, they had neuro-ophthalmology, oculoplasty, vitreoretinal, but still they wanted an experienced surgeon because morally they were totally affected because the press was troubling them. And every time they'll ask, will the patient get vision? The government is blinding them. So I said, as a surgeon, I answered every question. I told them, except political question, I will answer the thing. And I said, the problem is, you should find out why there is a pellet injury is happening. The pellet is happening because somebody is throwing stone on the police. And then this part, don't ask the surgeons. And I think you should ask the people, because we are responsible. And I'm also a citizen of India. And I think I'm responsible for what's happening. So everybody, all of us have a share, including voting the minister. So you can see meticulous wound repair is required. And the first surgery is very important. So we say in Tamil, no, முதலில் கோணம் முற்றிலும் கோலம். That means that if you don't do properly, and the whole thing will be a problem. So I think the first surgeon is important, whether he's in a village. I'm glad institutes like RIO, Shankar Nethralaya, and many others are training people, and all over India we have institutes, and I think ophthalmology we are not lacking in training, and I think wherever it is, so you should have a good meticulous primary wound suture so that there is no leaking wound which will cause hypertony. Wound healing gives strength to the vitrectomy surgery, and there's a spontaneous PVD. It actually probably happens in a week. So Dr. Ferenc Kuhn advises now, and I also follow the current trend, is to operate within 6 days. That means 100th hour, we want to repair the second repair. And EVL congestion decreases, reducing risk of secondary hemorrhage happening. And localization of foreign body, this is the most important one is history. And I always use the word high story to every resident, every optometrist in the hospital. People don't give importance. And I think you should know how the injury has happened, because it could be an iron piece, it could be you can identify the what are gone inside the eye by just history. And then the clinical examination, including double eversion of the eyelid, the gonioscopy, indirect ophthalmoscopy, focal corneal biodynamic, and biomicroscopically visible corneal lenticular or vitreous tract. Ancillary tests, still I feel India X-ray is important for, even though medical legally people will question. So I'm using a disclosure here. And ultrasound biomicroscopy, CT scan, MRI, not for the iron foreign bodies, and electrophysiological tests. So the management of intraocular foreign body, again, you can design, and this is for the vitrectomy surgeon, whether it's well visualized or it's poorly visualized, whether using a magnetic or a non-magnetic forceps. And you also have the giant magnet. I hope it's kept well polished, and I know I saw it in the museum. And we have used that. And once, I think I remember the Sliclam was not removed, and along with the artery forceps which was there, when we put the electromagnet, everything including the drape went on to the electromagnet. So it's so powerful. And those days, the only thing the patient wanted and the surgeon wanted in the same GOH here was the removal of foreign body. You were not bothered whether he got vision or not. And even the surgeon did not bother. So now, as a vitrectomy surgeon and as a primary wound repair or a primary trauma surgeon, my aim is to get excellent anatomical outcome and visual outcome. So we have magnets, there are a lot of design, and this is forceps, and then an electromagnet forceps diamond coated, which is a magnet, and that's a rare magnet, which is like a pencil magnet. And this is a Stern. I bought it from him. It opens 30 millimeters. And that's a thing. And this is also I've done. I used to work in Hindu hospital, and they didn't have instruments. I used ureter stone forceps, ENT forceps, because multidisciplinary hospital, and I think it has been published also. And I also designed this where a suction has been attached to the vitreous forceps, and so that you can grasp the foreign body. In 1984, I did a first glass foreign body removal in Shankarnath as a fellow. And I think when I was about to remove near the pars prima, because I didn't make the opening properly, it slipped from the forceps and just slashed the macula. And I can see still like a child jumping into the swimming pool, and the water splashing the retina, the blood vessel got torn and splashed and no view. And I think it was a terrible nightmare. And I remember I struggled to remove the blood and then do endolaser. And that was in a infected OT, so endolaser was not there. So it was a struggle. So that's why I decided, now I find a way how to prevent accidents happening when removing foreign body. So one is liberal scleral incision. This is a novel intraocular foreign body which I mentioned, which I use in the pellet removal. And it's like it just grasps and removes it. And then this is published in Indian Journal of Ophthalmology. And there are surgical procedures which will be through, and so this is Afikikai. You can see the meticulous corneal wound repair done by the Kashmir consultants. And then I'm again using the 3-prong forceps, just going into the eye after completing partial vitrectomy, grasping the pellet and then removing. And it's like sometimes there are 2 pellets in the eye, and most of the pellets, I think 95%, were through and through. It goes through the cornea, lens, vitreous, retina, choroid, sclera, and comes out into the orbit. And completing the foreign body removal, then I do a thorough vitreous base excision, identify if there is a wound, exit wound, then I actually make sure that the vitreous attached to it is totally trimmed. And you can see in this eye, I think you can see the exit wound, which is next to the optic disc. Fortunately, the optic nerve and the macula is healthy, so the patient can get 6/6 with a secondary intraocular implant. So the cornea surgeons and surgeons in like a column choroid, I do a laser around that exit site and not near the optic disc. And I'm using the retinal brush and clearing the surface of the retina, and then doing a fluid air exchange, and then air gas exchange. I usually use a C3F8, and this is the advantage of using the wide angle observation system. I should say that RIO, it's not RIO, I think it's my medical college is well equipped, and this is a patient who is again from Kashmir, who came exactly 6 days after the injury, and he could afford to come. So he's, I think, second or third patient I operated in Bombay. Otherwise, more than 1,000 patients were handled, and all were in Kashmir. There is a corneal wound repair done in Kashmir, and then they came, the ultrasound B scan showing vitreous hemorrhage, and there was a submacular hemorrhage. I did a vitrectomy, did a submacular drainage of the blood, and then you can see the silicone oil. And the patient got only counting figure because of the corneal irregularity. I think it can be sorted out later. So you can do the entire gamut of vitrectomy surgery to tackle. And this is again another aphakic eye, which you see, I think, is a similar one. So most of the eye looks the same. And then you also have, this is a 40-year-old male with a history of assault by 8 people. He was trying to separate 2 groups of people fighting, and then in between the event, and then the 8 people hammered him. He had a nasal bleed, he had a supraorbital laceration, for which primary suturing was done elsewhere. And actually, I lived in this compound, so I remember every day there was something like 20, 30 people coming with corneal foreign body. I hope it has stopped because the factories are nearby. We're having that iron things are flying and coming into the cornea. People get corneal ulcers and lose the eye also. And this patient had no light perception. He went to 2 doctors, and they all said enucleate. And then he had a CT. I did a CTEB scan. And then since he was advised evisceration in one hospital and enucleation in another hospital, he came to me. And so what was the plan? I decided to reconstruct, because so far I have not primary enucleated any eye. The reason is that we want to meticulously, it took 3.5 hours to do wound repair because the eye was chemosed, lid was chemosed, and you can see finally exposed the choroidal tear, which was parallel to the limbus, almost at the muscle ring. That means definitely ora serrata retina will be affected. And this is how the meticulous screening, and you can see the entire eye is full of its hemophthalmos. So I usually inject an air bubble in the AC, and then after I wait for about 15 days. Nowadays I wait only 6 days, but now this patient we waited 15 days. There was some descendant folds on the cornea. So what next? So we planned a 23 gauge vitrectomy, and that's what I did, a AC maintainer because of the suprachoroidal hemorrhage. I'm not able to see the internet. Yeah, okay. So I'm actually making a 23 gauge entry. Okay. Yeah. So you can see I use a maintainer. This is the best part to borrow technology from the anterior segment surgeon. And Dr. Michael Blumenthal was my good friend. I did a live SICS in Mumbai, and he introduced the AC maintainer. I think, if I remember correctly, even Dr. Daljit Singh also did not use. I assisted Dr. Daljit Singh in the same hospital here under Dr. C.P. Gupta's unit. At the time, postgraduates were not allowed to use, but I begged Dr. C.P. Gupta He's no more. He was the president of All India Ophthalmic, and then he allowed me to assist him. I actually wanted to go to Dr. Jagjit Singh and get trained for intraocular lens because nobody was doing intraocular lens that time, even in Natarajan or in Bombay also. So he was the one who was one of the pioneers, along with Dr. Y.C. Paranchpe in Sangli. Both these places are small. Later, Dr. Daljit Singh became my own fan, and he used to visit my OT. My internet issue. I'm using this. You have Wi-Fi? So you saw the AC maintainer, and then I'm clearing the center of the pupil. It's working, okay. And I'm also clearing the vitreous hemorrhage. The idea is AC maintenance because you don't know where is the pars plana, and then if you have the supracortical infusion because of the wrong placement of a infusion line, you'll have a problem. So you have to be ambidextrous. You have to have a good temperament as a vitreous surgeon to manage these sort of complications. And so it's a meticulous vitreous dissection, and which you have to remove. And I'm using one side endoilluminator, the 3-port pars plana vitrectomy, and then you can at present I'm actually, after reattaching the retina, I'm using the same AC maintainer to inject the silicone oil, and then AC I use the air so that you know that the cornea to posterior to the iris you have the air bubble so that the silicone oil is not filled more than what is required. And still, I think then complete the oil injection. So I nowadays use 3D. Net is the problem. Is net the issue? Oh, yeah. Okay. So this is our 3D surgery setup. The surgeon, all the nurse, the doctor, the fellows, the assistants, all are actually using the 3D glass. And this is Corona time, using the PPE and all this I use a double glove. And that's my nurse who's working with me last 33 years, the day I left Madras. And from there, she's assisting me. So you can imagine she tolerates me. And I treat her like my mother, but I fight. Oh, net is slow. Okay. Anyhow, so I now do all my surgeries only in 3D surgery. So one is an excellent recording. And I come to the last slide. So I'm immediately agreed. He didn't even ask me, sorry, please come. And so I like this. So started with ITG Hospital with the Leo Club of Khalsa College. Nowadays, I motivate and inspire. I have a 10-year-old young children, either enucleated one eye with retinoblastoma or trauma patient operated. Whether they got vision or not, they love, and some of them have vision. And those people, I motivate them. I start Zoom lectures for them. And similarly, I did this on Saturday for the Leo Club. And now I've decided to make all the Khalsa College, there are about 10,000 students, to be my ambassador for pledge. Login and Shri. In case you can log in, you can check that. So each one can log in, and you can get a thanks to Masurkar, the entire who is actually given this. So pledgemyeyes.org, and we have also, and I think Gopal Pillai is doing some competition. So based on that, here also we have a competition with the Leo Club, Lions Club, and Aditya Jodh. So it will be a 2-week program, and this is what all the people that institutes and some should do it in a big way. Unfortunately, every year we are fighting, struggling. I made a 5-point program. The 5th point was eye donation. From my childhood, I am supporting this eye donation because of that, where after thanks to GOH, Dr. Anand Babu was there and a team that time, and later, now 20 years along with Dr. Velaidam, I'm visiting. Already decided, probably in 2019, I'll celebrate 200, and thank God I got elected as vice president in 2017, and then 2019 I did this world over. So this is again, I think Mohammed Abrar is here. His father clicked these pictures, and I would like to pay homage to him and be silent for about 30 seconds. And I really miss him because I told Dr. Prakash I have to do something for Dr. Syed Arshad. He's also a GOH alumni, 1984 to 86. He did his PG. 86, I think so, because I was already a consultant in Chennai. So let us remain 30 seconds silence. May his soul rest in peace. Thank you. So actually, I'm emotional because I convinced him, and I think Dr. Abrar has to work with Dr. Prakash and work on this enormous treasure Dr. Syed Arshad has created, which is in his computer or in his thing. And I think he told me he took for these 3 pictures. He took each picture, I think, almost 6 hours to what do you call? I don't know what you use the word for a photography, which I don't understand, because I just take a photo and put it. But he said even this picture on the top, the lollywod, which I saw it in the previous speaker last slide, where there's a tree growing, and he's very upset the tree was growing, and he said PWD did not listen to him. And I don't mind telling this, but I think he had a good heart. He only wanted to support GOH, which I know he swore on God and told me. And I want all of you here to remember that he only showed all that to say that to rectify. So I'm here as a volunteer representing All India Ophthalmic Society. We got, I think, totally so far 10 lakhs. And I'm glad there is a black stone there, which surprisingly I've given the maximum amount in 2000, year 2000, because that year was my 100th year of grandfather, who worked here in this hospital in 1930 to 1941. And Dr. G. N. Rao's father worked here. Dr. G. Venkateswamy was a postgraduate here. Dr. Badrinath was an undergraduate. So I'm glad that all of you are from this institute. So with this, thank you very much. And that's my late Dr. Natarajan Pillai. They lived in the 10 Marshalls Road, which is the last house in the next compound. And then my father lived in the same in 1955. I was born in Madurai in 1957. From 57 November till, say, I think April 1969, because I studied in St. Anthony's High School in the same road. So we used to go to the church. I used to go to the Pilayar Koil here. And then, so one day we pray Pilayar and then Jesus. And then Christmas, I've never seen procession from a church, but this church has a procession which comes into the eye hospital compound, as well as any other Tamil festival. So I think I'm born here. I will live here all the time mentally. So thank you very much, and thanks to all of you for giving this opportunity to speak here today. So, and always, I think not only today, I think any time I want to come here, thanks to Dr. Prakash and all the predecessors who were directors, and right from my father's time, 87. I proudly can say that because I didn't like to work with my father, so I worked in about 87 unit, every unit except him, because he used to scold me, and I'm glad I remember him today, not in a bad way. Fortunately, I did not become a rebel just because he was fighting with me, but I think whatever he fought and he corrected me, and he used to tell me, just go for the exam, he'll ask some question, and I'll fumble, he'll say you will fail. But I'm glad I didn't fail any exam, and I didn't fail any elections also. So thanks to all of you, because the same RIO which came in 2002, headed by Dr. Radhakrishnan at that time, to support me in the Ahmedabad election. And I think after that, no more turning back. So, நான் பிறந்தது இந்த மண்ணிலே தான், I think everything is there. So I wrote this to Rajnikant, that you are born in Maharashtra and you are contributing in Tamil Nadu. I am born in Tamil Nadu, contributing to Maharashtra, India, and the world. Thank you.
Thank you very much, sir.
Thank you.
Sir, it's a great time we had rich experience with management of post-treatment ocular trauma, and it's really a proud occasion for us that he's honorable alumnus of RIOGOH, and he had a lot of glory to RIOGOH by being one of the topmost world-renowned ocular surgeons. So it's a great credit to RIOGOH. Thank you very much, sir, for sharing your experience.
Thank you. But I'll be happy only, as usual, postgraduates have to ask me question. Otherwise, I'll ask question. No, Sharmila knows. அவர் கவனிக்கவே இல்லை. அவர் இன்டர்நெட்டே பார்த்துட்டு இருந்தார். Yes, sir, nobody has doubt or any question. No, I want you to remove that inhibition that you cannot ask questions. So I want you to ask any question. Only some question you have to ask. Otherwise, I won't go. Sharmila knows that. Sharmila also can't go home. Madam, யாராவது ஒரு ஸ்டூடெண்ட் கேளுங்க, பேர் சொல்லி கேளுங்க.
It's a large magnetic object in the retina. We cannot take it out to the cloth. We cannot take it out. Use the magnet from the outside.
No, I don't recommend magnet because it'll come through so much force. Now, however large it is, you can enlarge the wound. Either a scleral wound, which is a risk because dialysis will happen. I prefer doing a lensectomy, vitrectomy. So you have a transpupillary, you can remove it through the AC. So coat the cornea. I have maybe I can show a video. But I don't know whether I'll get my. No, you can go through the transscleral approach. So I prefer because using a foreign magnet will just pull everything and come, and that's the problem. Because it'll that's why the olden days, as I said, electromagnet they used, and it was it's opening. Anyway, if I get the video, I'll show you. So we actually make hold the, as I said, 30 millimeter opening forceps are available. You can grasp it, bring it to the pupillary region, and open the cornea and remove it through the clear corneal or a corneal. and then suture the cornea. So that's why you have to be a, pole-to-pole surgeon. But I think magnet only if it is a small piece, so easier. And even a transcleral approach, I don't like. So I have done earlier, but if only when it's near the ora serrata, not involving, it will come through the layers of that. Here, at least you can see the foreign body. You can go through pars plana, hold it with the vitreous forceps, bring it to the pupil region, and you can use a large, any regular forceps and remove. So anybody knows what is entomology?
Etymology, the history of
No, entomology.
how the word came into being.
No, that is etymology. But I asked entomology. Yeah. So everywhere I put this 200 years of ophthalmology in India, thanks to GOH. I think, no.
The president was a very proud moment for us also. The first line was GOH. First line in his presentation when he took over as the president of the AOS. The first line was GOH, and it was like a very proud moment for all of us there. It was like when AR had on the stage, like snapping the leaves the double again. So it was a really wonderful moment, and I'm sure it was third always speak about GOH. And he was one who popularized the 200 years of GOH everywhere, even in the work stage. Even had a podium video, right?
I presented in the Kogan Ophthalmic History Society meeting, and even now Academy, I'm fighting with them because the Academy has got a $12 million eye museum. They're not able to inaugurate because of the. So definitely, no, I'm proud. I'm proud of. I brought the Ramsco, what do you call the. And this I think this missed from my presentation. Anyhow, this is a flaring arch ring, and then my cornea surgeon is Dr. Kavita Rao. She told me this cornea is terrible, no point in doing surgery. But I decided that you can see the phlegm-like material after the injury, and so we used the flaring arch ring, and I first used it in GOH only. So many times I wonder, because I've seen explosive happening, and it happened when I assisted Dr. Manju Kulkarni when she was doing a PK. So I'm not scared, and I think this is what the best thing I've learned is to see all complications happening in front of you. And I think the good surgeon is you would have a lion's heart to manage it. And that's what credit goes to Dr. Badrinath, who trained me. And every day I remember the alma mater, as Sharmila said, every presentation will have GOH, because I'm trained, I'm born as an eye doctor here. Because from the age of 5, I am exposed to ophthalmology, even though I lived from my birth. My next door was Dr. Swamiraj, who is a professor of ophthalmology. Now I think not in SRM, some other medical college. And Dr. Arumali Varman, and he was actually, his father was chief, and my father was second unit that time in Stanley. Then they both were here in GOH. So from the age of 5, I remember duty. That boy comes and calls my father for foreign body removal, and I many times when nobody is there, I used to put torch. So my first experience of using the ophthalmoscope is when my father was not seeing patients. I used to examine dogs and cats' eyes, and I've seen the first retina. I was glittering. I cannot forget that. There was so much glittering. I didn't know what was happening. I thought something like a cracker inside there. That's my impression of the first examination. And so I always used to wonder what my father was doing with the ophthalmoscope. And I met the founder of VG Pandit Das, in the same house here. And he told me, and you can see this is a vitreous hemorrhage, which is like a thick phlegm, like a, the eye anesthetist was telling me, is it worth operating such a bad end ophthalmology? You'll be seeing, it's like a miraculous thing will happen, because you'll be seeing after clearing the entire thick which is exudates, and because of the PVD happened, you'll see the entire retina all right and optic disc healthy, and you can see the infusion line, and that's the advantage of using the class A cart or the other character processes, Morris Landers. And both of them are my friends. And they have designed the character processes so that when the cornea is opaque, you can remove the cornea and then use either a preserved cornea or the therapeutic graft. And then later you can replace it with optical graft. So the idea is not to give up. And I think you spending hours, this is what the New York Times person asked me, is it worthwhile doing so much for a patient for 3 hours and 4 hours? I think it was backbreaking, but now because of my dance, my exercise, my antagonist muscle and protagonist muscle, that means the back muscle and the front muscles are strong, and I think nothing will happen to your back. You can see when we put the thing, you can see the optic disc and the retina clear. And when we started, you saw whether will this eye survive. And I also give an intravitreal. Then the cornea is done by Dr. Kavita Rao, and I'm again grateful to Professor Natarajan, Dr. M. Mohan Rajan's father, who allowed me to operate a PK as a postgraduate. I was only a DO, but he allowed me to do. So he allowed me to do any surgery I wanted, provided there was a good assistant surgeons are assisting me. And this is again, I remember once before Dr. C.P. Gupta came, I started doing a DCR and teaching the undergraduates. I was just a second year DO. So he came and got very angry. He said, how can you start without even assistant? You can start a OT. It was not supposed to be done. I said, because I was doing teaching, I over enthusiastic, and he really reprimanded me by not allowing me to come to OT for 1 week to teach me a lesson. But it was good. I think what I did was I didn't follow the protocol. And here you can see the eye, it's like internal evisceration. You can see the iris totally inflamed because of the severe exudates. Now you saw I planned a temporary corrective processes, but I'm actually doing an open sky vitrectomy, and flaring the ring is in place. And I clear the whitish and yellowish material, but I don't know what I'm removing because it looks like I'm actually cutting the even the suppurative retina. That means it's full of pus and toxic damage the retina. But whatever it is a 10-year-old boy, and the patient came 20 days later. I wish they would have come early. And I was done the maximum number of endophthalmitis vitrectomy in 1984 to 88 in Shankarnetra lab, because nobody was doing vitrectomy in India. Can you believe it? And I think, so every day we had 2 endophthalmitis coming. And you can see the eye, which we started as a terrible eye, we could save the eye. And this is what I tell the patient, the risk of surgery is you may lose the eye. They will say, already in OPL, what is there to lose? I said, you lose the eye. The eyeball can be shrunk and you will keep on grumbling or you will take me to court. So I said, if you are after surgery, if your eye is there or not, if you get vision or not, if you are ready, then I will operate. Otherwise, I don't want to operate. I always tell them, I operate, I get this is an intravitreal antibiotic injection. So we give a Vanco with the ceftazidime, and a trauma, sometimes I give a clindamycin too. So this is a post-operative. You can see there was a counting finger close to face, and this was the NOPL and the post-op counting finger. So this is again another traumatic endophthalmitis, and you can see severe. I think that whatever the you see, I think however bad it is, I think my suggestion is that here I'm using the MVR blade and entering the anterior segment, having the infusion line in the anterior chamber, and then you are clearing the vitreous from exudates, and finally you conclude by having a fluid air exchange, and then whatever keep the eye as clean as possible, and make sure that when you're going near the retina, don't have suction. And then here you see some remnant of blood. And this patient required multiple intravitreal injection of antibiotic post-surgery, and maybe sometimes every 48 hours post-operatively. And the prognosis is a problem in this. So this is again thanks to the 200 years of ophthalmology again. I'm not able to get that video. I removed a toy bullet from the eye. So I think our idea is now to see whether we'll get vision, and even whether you get vision or not, I think you should attempt very thoroughly, and that's what I recommend. And patient space as well as the meticulous surgery phase. And I think now I have patients who are not got vision after my surgery, not because of me, because of the pathology, either it is a diabetes or a PVR or trauma. I think those patients are giving me donation. They honor me with some function. Recently, I did a camp in a place called Sinnar, which is in Maharashtra near Nasik, where there is a 1,000-year-old temple, Shiva temple. And that patient, I didn't even remember, but he suddenly called and said, I want a camp in my grandmother's name. I've done 5 surgeries from the age of 7. He's now 23-year-old with he's a CA. And I asked him, why did you do a camp and you didn't get a vision? He says, no, you tried your best. And still I'm hopeful you will find some artificial retina so that I can see. But I couldn't tell him anything. He has a false hope that I will give him vision. But anyway, I'm clear in my mind that we are working on retinal stem cell, we are working on artificial retina, and also on genetic engineering. So as Dr. Prakash said, that whatever I think I'm doing, finally, all credit to GYH. Thank you.
Thank you, sir, for your so messages. Never give a complication with a factory complication on post-operative complication. Give your best to the patient, and I'm sure the patient will be happy. Thanks to my coalition for generous response to the event as well as and if there are no questions, we'll wind up the session. Thank you very much, sir.
Thank you.